Hi everyone, and in this video, I'll be discussing thyroid hormones and anti-thyroid drugs. Now, there are two important problems we see when we start our practice. One is hypothyroidism, and one more is hyperthyroidism. For managing hypothyroidism, there is a drug called levothyroxine. For managing hyperthyroidism, we have a drug, and they are called as anti-thyroid drugs. Do we see these cases in hospitals? Yes, we see them, and that's why the topic has been kept for you. And also, the questions come from here. So let us start our journey, the thyroid hormone and anti-thyroid drugs. Now, first of all, there are two important problems I told you. One is hypothyroidism, and one more is hyperthyroidism. So we have hypothyroidism and hyperthyroidism. Now, what is the problem in hypo? There is decrease in T3 and T4, and there is increase in TSH. So that is the investigation. Now, in hyperthyroidism, there is increase in T3, increase in T4, but there is decrease in TSH. Now, to manage hypothyroidism, what we use is the drug by the name levothyroxine. The name is called levothyroxine. It is the T4 hormone. Now, for managing hyperthyroidism, we use a drug, and these drugs are called as anti-thyroid drugs. So these are called as anti-thyroid drugs. Now, Graves' disease, not only Graves' disease, we can see them in one more condition, that is toxic nodular goiter. So, hyperthyroidism, Graves' disease, toxic nodular goiter, in all these conditions, we see the increase in T3, T4 and decrease in TSH, and the management is with anti-thyroid drugs. So in this video, we'll be first discussing the concept about thyroid hormones, and then we discuss anti-thyroid drugs. So first, the thyroid hormones. Basically, we have two important hormones. One is called levothyroxine, and one more is liothyronine. So we have levothyroxine and liothyronine. What is the difference between the two? Let us understand. Levothyroxine is nothing but levothyroxine is the T4 hormone. Liothyronine is the T3. Now, importantly, liothyronine is most potent hormone. It is most potent and most efficacious. This is less potent and less efficacy. And liothyronine is more active, and this is less active hormone. Okay, I think you have studied that in physiology. It's just a revision for you. What about the half-life? The half-life of liothyronine is approximately 1 to 2 days, and that of levothyroxine T4, the half-life is very long, around 5 to 7 days. Around 5 to 7 days. Now, where do you use it? Liothyronine mainly used in the treatment of mixed edema coma. So it's an emergency where the thyroxine levels have gone so much down, patient will slip into coma. It is called mixed edema coma. Now, where do you use the T4, that is levothyroxine? Levothyroxine mainly used for mixed edema. It is also used in mixed edema coma. It is one of the commonly prescribed drugs to manage hypothyroidism. And the same hypothyroidism in a child, it is called cretinism. So we use it in cretinism. Levothyroxine is also used in a cancer called papillary carcinoma of thyroid. So you may ask a question, sir, how come it is useful in papillary carcinoma of thyroid? Now please understand, TSH is the stimulant for increasing the papillary carcinoma of thyroid. So papillary carcinoma of thyroid depends on TSH. Now when we give T4, you know that T4 will decrease the activity of TSH. Now obviously when you decrease the activity of TSH, what happens? When the TSH decreases, the cancer decreases. Now, sir, do we use drugs for this papillary carcinoma of thyroid? Remember, we do surgery. But many a times surgery is not possible. In inoperable cases, then we use this levothyroxine, otherwise surgery is the best one. So the simple meaning is papillary carcinoma depends on TSH and that will increase the papillary carcinoma. So what we do, we give T4 which suppresses the TSH, and when you suppress TSH, the cancer will also decrease. This is the meaning. So that is about levothyroxine, but I want to tell you certain important pharmacokinetics about levothyroxine. Please listen to that. Very much important. Levothyroxine pharmacokinetic, what is the important point? Remember, when we give it orally, it has approximately 75% bioavailability. Second important thing is food interferes with absorption. So it has to be taken in empty stomach. So the drug has to be taken in empty stomach. And third important, patient, if you tell you take it at empty stomach, they will take breakfast at 11 o'clock, 12 o'clock in the afternoon. So tell them you have to take the drug early morning so that you mimic the physiology. So remember, levothyroxine, most important. Orally, when we give it, approximately 75% viability. You have to instruct a patient to take it in empty stomach and don't give it with drugs or with food. Early morning is the ideal time, and the name is levothyroxine. So we understood the thyroid hormones. What is the important aspect in that? So once we have understood thyroid hormone, let us understand the anti-thyroid drugs. We'll understand the anti-thyroid drugs. Now we know that anti-thyroid drugs are the drugs used to manage hyperthyroidism. So what we should do, we should decrease the release of T3 and T4 because that is the one which is causing hyperthyroidism. Now to understand that, let us understand certain basic physiology here. Let me write a thyroid follicle. What happens there? Let us understand. So let me write here. Yeah. Now, what happens initially? There is entry of sodium along with iodide. So if we call it as sodium iodide symport. So when the iodine enters inside, iodine is converted into iodinium, and that process is called oxidation. This iodide, that is iodinium, will combine with thyroglobulin. There is a tyrosine residue in thyroglobulin. It combines with that, and that is what we mean by monoiodothyroxine. We get monoiodothyroxine, and that step is called organification. So once that is done, monoiodothyroxine combines with one more monoiodothyroxine to get diiodothyroxine. Now MIT will marry DIT and you get the hormone T3. And DIT will marry DIT and you get T4. So they are stored in the thyroid follicle, and whenever the impulse come, the T4 and T3 are released. But you know that the abundant one is T4. The abundant one, the circulation is T4 and minute is T3. See the beauty of nature. T3 is more active, that's why it has kept low. T4 is less active, that's why T4 is abundant in circulation. Now when T4 is released, T4 is converted into the active one T3 and the enzyme is called deiodinase. So the enzyme which convert that is called dehydrogenase. So this is what the meaning of thyroid hormone synthesis. Now since we combined MIT, DIT and all, this process is called coupling. This process is called coupling, and hormone which okay, let me repeat here. So we have oxidation, organification and coupling, and that is done by an enzyme called TPO. So what is TPO? TPO stands for thyroid peroxidase. So thyroid peroxidase is the enzyme which will convert the iodide into iodinium, then organification and coupling. All these reactions are done by thyroid peroxidase. So this is a brief physiology. I'm not going in detail because you have studied in physiology. So I just want you to understand the drug targets. Now you just pause the video and tell me, where should I block? What are the targets? Yes, obviously you can block the sodium iodide symport. Second, you can inhibit the enzyme thyroid peroxidase. Number 3, you can stop the release of T3, T4. Number 4, you can inhibit the enzyme dehydrogenase because the most active form should not come. And then last one is, so what will you do? We have to destroy the thyroid gland. Number 5, destroy the gland itself. So there are 5 strategies of antithyroid drugs. Number 1, inhibit sodium iodide symport. Number 2, inhibit enzyme thyroid peroxidase. Number 3, stop the release. Number 4, inhibit the enzyme dehydrogenase. Number 5, destroy the thyroid gland. So once we understood this basics, let us move on and discuss the drugs. In the drugs number 1, we have sodium iodide symport inhibitors. So we have sodium iodide symport inhibitors, and the name is called thiocyanates. So do you remember when we use sodium nitroprusside, it generates thiocyanate. So the drug sodium nitroprusside can also cause hypothyroidism. Another is perchlorates. So perchlorates, one of the adverse effect is it can produce aplastic anemia. And number 3, we have fluoroborates. Now these drugs are outdated nowadays. We are not going to use them in the therapies. Just you should understand the mechanism of action, that's it. The most important group what we are going to discuss, the second group of drugs are called thioamides. So the group name is thioamides. In that we have 2 important mechanisms and drugs to discuss. Now the drugs which inhibit thyroid peroxidase, not only they inhibit thyroid peroxidase, they also inhibit the conversion of T4 to T3. So the drug which has both the mechanism, the name is called propyl thiouracil. So the name is propyl thiouracil. And the drugs which inhibit only thyroid peroxidase, so that group drug name is called carbimazole. So the name is carbimazole. Now carbimazole is a prodrug. After metabolism, it will give rise to methimazole. So it will give rise to methimazole. Remember, carbimazole is a prodrug. Okay. So they are thiamides, but they have different mechanisms. Only thing is propyl thiouracil is additional mechanism of action. That's it. Let me do one thing. Let me write what are the differences between the two, propyl thiouracil and carbimazole. The difference is propyl thiouracil is less potent. Now these are more potent. The drug is shorter acting. Propyltyrosol is short acting. So you have to give 4 times in a day. And these are longer acting. And in the thyroid gland itself, they have longer half-life. It is called intrathyroidal half-life, is very much long. Then another important, propyltyrosol has high plasma protein binding. So it binds the plasma protein very much. So I may ask you a question, sir, what is the advantage of high plasma protein binding? The advantage is two. What is the advantage number one? Advantage number one, because of high plasma protein binding, it will not enter the placenta easily. So that's why you can prefer this drug in pregnancy, particularly first trimester. Suppose a pregnant woman has hyperthyroidism and she is in first trimester. What is the preferred drug is propylthiouracil. Now it is also preferred in a lactating woman. Lactating woman, it is preferred because here also it will not come in the breast milk so easily. Now coming to these drugs are teratogenic, particularly in first trimester. They are teratogenic in first trimester. So what is the teratogenic effect do they produce? Number one, they produce scalp defect. Scalp defect, it is also called as cutis aplasia. Cutis aplasia. And they also produce esophageal and coronal atresia. Coronal as well as esophageal atresia. And also they can produce omphalo mesenteric duct anomalies. So if it is too much lengthier, please remember, mainly you should remember these drugs produce scalp defect. That was the question asked in your exams. That was the question asked in your exam, which drugs can produce the scalp defect. So in the first trimester, these are teratogenic drugs. So we cannot use them, either carbimazole or methimazole. Now, sir, what about in second trimester? The problem when we use propyltyrosol is propyltyrosol, if you continue it, it is hepatotoxic. So because of that, we are not going to use it in the next trimester. Suppose if they ask you second and third trimester, pregnancy, what is the drug of choice? Then you can write them as drug of choice. Either carbi or methimazole will be the drug of choice. Now you may ask a question, why not propyltyrosol? Because it is hepatotoxic. Now these are also drug of choice for the Graves disease, or what we call it as toxic nodular goiter, and any hyperthyroidism, we use them. The reason is simple, because these are longer acting, that's the advantage, and they stay in the thyroid for very long period. Now they don't have hepatotoxic problem. The second important problem is propyltyrosol increases C-ANCA levels in more than 50% of patients. So that is one specialty, one problem with the drug. Then, can we use this drug in thyroid storm? This drug is used in thyroid storm. Now, what is thyroid storm? I will explain it later. Until now, remember, thyroid storm is a complication during thyroid surgery. Now, why it is used? Because it inhibits the conversion of T4 to T3. Now, these drugs, they are not used in thyroid storm. So very much important. The difference between the two is very, very much important. So we are discussing thiamides and propyltyrosine inhibits the thyroid peroxidase as well as inhibits the peripheral conversion of T4, T3. And carbimazole, methimazole, they inhibit only the thyroid peroxidase. The commonly asked question is, which are terogenic? First trimester, they produce scalp defect, that is carbimazole or methimazole. First trimester, propylthyroid is safe because it is highly plus protein binding. Why can't we continue further? The reason is simple, it is hepatotoxic and less efficacious, less potent, and it is shorter acting. So once we are done with that, let us move on to the next. They decrease T3, T4 release. So what are these drugs which decrease T3, T4 release? And they are called sodium iodide, potassium iodide, and an iodine called Lugol's iodine. Now this Lugol's iodine is made up of 5% iodine plus 10% potassium iodide. Now these decrease the release of thyroxine, and these are the fastest acting antithyroid drug. Fastest acting antithyroid drugs. Clear? Now, once we know that, where to use them? Now, these are used before surgery. Suppose we are doing a thyroid surgery for a toxic nodule goiter or a Graves' disease. Before surgery, we are using it. Now, what is the plan? What we do is 2 to 3 months before surgery, we start the patient on either carbimazole or propyltyrosine. So these will decrease the synthesis of T3 and T4. So that is decrease. That is one. Second, what we do is before surgery 1 or 2 days preoperatively, we give the iodides. Now, this question was asked, why do we give preoperatively iodides? Number one, they make the gland firm, they make the gland less vascular. Now, what is the advantage of making a gland firm and less vascular? Now, during surgery, the advantage is there is decrease in bleeding. So, decrease bleeding during surgery. So, the question was asked, what drug is used preoperatively to decrease bleeding during surgery? They are iodides. And also clear surgical field because the decreased bleeding. And also there is decreased chance of thyroid storm. So these are the advantages. Why do we give iodides preoperatively? Simply remember, it makes the gland firm and less vascular. So during surgery, the bleeding risk is lesser, thyroid storm is lesser, and you have a clear field to operate on. So that's why. So before thyroid surgery, to avoid this, we give carbimazole or methimazole and decrease thyroid synthesis. Preoperatively, we add iodides. So that is one use. Second use of them, they are used to manage thyroid storm. They are used to manage thyroid storm. What is thyroid storm? Suppose you are doing a Graves' disease or hyperthyroidism patient or toxic nodule goiter. When you're doing that surgery, suddenly when you cut the thyroid gland, there is a chance that thyroxine gets released into circulation. So when it releases into circulation, it will cause the CVS manifestation like tachycardia, arrhythmias, and all these things. So this will decrease the chance of thyroid storm, and they are iodides. And how do they work in thyroid storm? They decrease the release of T3 and T4. The fourth important antithyroid drug what we are going to discuss is what happens in the periphery. T4 is converted into T3, and the enzyme is called deiodinase. And that enzyme is inhibited by certain drugs, and we already know propyl thiouracil. So we understood that already. Then one more beta blocker, propranolol, and one more, a steroid called hydrocortisone. Please remember, all these are used in the management of thyroid storm. So it's an intraoperative complication and we use them. Thyroid storm. The fifth target. So the fifth target is destroy thyroid gland. Destroy thyroid gland. What is that? The drug name is radioactive iodine. So it is called as radioactive iodine 131. It emits two particles, gamma and beta. Gamma is required for doing a scan, so that you will understand in radiology, to scan to check whether there is toxic nodal goiter or any other cancers. We use it for scanning. Beta is the one which we use to destroy thyroid gland. Now these radioactive materials have a half-life, and that is called physical half-life. Physical half-life, and it is around 8 days for radioactive iodine. Now what happens when we give radioactive iodine? This is the thyroid follicle. So when we give radioactive iodine, the radioactive iodine enters and emits a beta particle. The beta particle will penetrate around 0.5 to 2 millimeters, and by penetrating that, it will destroy the thyroid gland. So it will not penetrate too much. It will penetrate 0.5 to 2 millimeters and destroy the thyroid gland. Sir, where do you use it? What is the advantage of this? Okay, so we'll understand what are the advantages of radioactive iodine. Advantages of radioactive iodine 131. What are the advantages? Number one, no scar. Suppose you don't want to undergo a surgery, patient doesn't want to undergo surgery, then they can be given radioactive iodine and destroy the thyroid gland completely. Second important is this procedure is less expensive. You know that surgery is costlier, and this is a drug, it is less costlier. Another important thing is which patient is advantageous. Patient not fit for surgery. So if the patient is elderly, he has some cardiac complications, and you cannot give general anesthesia and do surgeries, in those patients, don't do surgery. You can give radioactive iodine. Second important thing is patient not willing for surgery. So some patients, they don't want surgery. They tell us, give some drugs and treat us. For them, it is better. Another important thing is when the surgeon has operated, many a time some remnant thyroid has remained. So again, you don't have to do the surgery. Give this radioactive iodine. The remnant thyroid is destroyed. So to remove, to destroy remnant thyroid after surgery. So these are the advantages of radioactive iodine. But what is the disadvantage? What are the disadvantages? So disadvantage, obviously, when you destroy thyroid gland, patients will have permanent hypothyroidism. Permanent hypothyroidism, and because of that, they should get lifelong levothyroxine should be given. Lifelong levothyroxine is given because of permanent hypothyroidism. The second problem is it is contraindicated in pregnant. You cannot give it in pregnancy. Number two, you cannot give it in lactating mother. You cannot give it in children's. What is the reason why we cannot give in them? The reason is simple. Number one, they produce permanent hypothyroidism. The hypothyroidism is permanent, and we know all these patients, pregnant, lactating, and children, require thyroxine very much in that phase of life. Second, what we are giving is radioactive material. So radioactive material should not be given to these pregnant, lactating, and children. So this is the disadvantage of the radioactive iodine. These are the advantages, and this is how the radioactive iodine works, and we call it as radioactive iodine 131. Once we have understood the antithyroid drugs, there is a chance that they can also ask you in the exam, what are the drugs which cause hypothyroidism? So drugs causing hypothyroidism, I will give the important list. Mainly, obviously, antithyroid drugs, they should produce hypothyroidism. The name itself is telling you antithyroid drugs. The next one is an antihypertensive that is called sodium nitroprusside. We have a drug used in mania. I think you would have guessed the drug now, and that is called lithium. And then we have another drug which is used in tuberculosis. It is called ethionamide and PAS, para-aminosalicylate. Can you guess one more, an antiarrhythmic drug, and that is called amiodarone. Now amiodarone is the drug which inhibits the conversion of T4 to T3. So amiodarone inhibits the conversion of T4 to T3, and these are the drugs which cause hypothyroidism. Okay, so summarizing the thyroid hormone and antithyroid drug, remember thyroid hormones, we have basically two things: levothyroxine, that is T4, levothyroxine is T3. The most abundant is T4 and less abundant is T3, but more active, more potent, more efficacious T3. So levothyroxine, we use it in hypothyroidism, cretinism, and we use it in myxedema coma, and also papillary carcinoma of thyroid. And it has to be taken in empty stomach early morning. Now to treat hyperthyroidism, we have antithyroid drug, the drugs which inhibit the sodium iodide import, and mainly you have to concentrate on the thyroid peroxidase inhibitor. They are called thioamides. They are called thioamides, propylthiouracil and carbimazole. First trimester of pregnancy, hyperthyroidism drug of choice is propylthiouracil. Second and third, carbimazole. What is the drug of choice for Graves' disease? It is carbimazole or methimazole. What is the problem with thiamides, agranulocytosis? Is it common? Rare problem. Stop the drug, you will stop the adverse effect. How do you do that? Check the patient history. Fever, if there is fever, if there is sore throat, check the CBC. Then we have the iodides which inhibit the release of T3, T4. They are the fastest acting antithyroid drugs. Now we use them preoperatively before thyroid surgery and also in thyroid storm. Now apart from that, we have the T4 to T3 inhibition, and that is done by propylthiouracil, propranolol, and hydrocortisone. Then another important aspect we need to understand is radioactive iodine. It emits beta particles which destroy the thyroid gland permanently. I have discussed what is the advantage and disadvantage. If the patient is not fit for surgery, not willing for surgery, some remnant thyroid use it. It is contraindicated in pregnant children and lactation. Now one more thing you can ask, what are the drugs used in thyroid storm? Suppose there is thyroid storm, what are the drugs used? In thyroid storm, the drugs used are propranolol. Now why do we use propranolol? Propranolol is a beta blocker. So two things it will do. It decreases the serious manifestations because of thyroxine. It can cause increase in heart rate, increase the BP arrhythmia. And also it inhibits the conversion of T4 to T3. Now if the patient is asthmatic, if patient is a bronchial asthma patient, then we don't give propranolol. We use the calcium channel blocker, that is verapamil. Another important aspect, along with propranolol, we also use propylthiouracil. The reason is it also inhibits the conversion of T4 to T3. Then another group of drug used for thyroxine are iodides. The advantage is they decrease the T3, T4 release. And one more drug that is used in thyroxine is steroid, hydrocortisone. So it is used to overcome shock. So that is the drugs used for thyroid storm. So with that, we have finished the drugs, that is thyroid hormone and antithyroid drugs. Thank you all.